Alice Long, and I work here at the Working Out Institute here at BSMS. So our speaker this evening is Dr Neil Singh. Neil studied medicine at the University of Cambridge, where he won the Cuthbert Prize in Medical Humanities. After initially working in hospital medicine as an academic trainee and a clinical research fellow at the University of Cambridge, working on stem cell biology, he realised his interest lay not at the level of molecules, but rather in the study of the health determinants of entire populations. He completed a Master's in Public Health at the American University of Beirut as an NIH-funded Sharp Scholar. He is now proud to be a primary care physician working locally with a particular clinical interest in caring for vulnerable groups. Neil is also a writer, and his work on health is featured in The Independent, The New Statesman, and Open Democracy. So let's please welcome Dr. Neil Singh.
All right, can you hear me all right? Is that coming through? Welcome everyone to the medical school. Lovely to see you all here tonight. Really nice to see some young faces here tonight. So, you're all here to hear me give a talk called How to Save a Life. So I'm not sure what you're expecting. Possibly you're expecting some of this. Tonight we're not going to talk about resuscitation at all. But this is certainly my idea of what I was going into medicine to do, and maybe some of you are in the same position. When I was young and I, about your age, decided I wanted to do medicine, I wanted to save lives. I wanted to help people and use my intellect and so on to save lives and help people live better lives. And so I had this sort of naive and heroic view of medicine that, you in your white coat can come along and save the day, and you feel great about it, and patients love you. And to some degree, you do get an opportunity to do that. But what I'm here to talk about, as a GP who works locally and teaches in the medical school, is how, in truth, the things that keep people healthy are less heroic than that. And they're less sexy, they're less exciting, but actually, if you're into that kind of thing, it can be very rewarding, and they can help people live much healthier lives. So every story has a beginning, and this is mine. This is my grandfather. This photo is taken in India, in Bihar, in a very poor state in Bihar, of India, called Bihar. And you'll notice that he's operating. He was a surgeon. He came from a poor family of farmers and studied to become a general surgeon. And that's my auntie on the right there. So he was training how to do surgery. You'll also notice that he's wearing a vest. Yeah. This is not him at the hospital. This is him at home. And these people are illiterate colleagues of his who help with surgery. And so this really was my first picture of medicine. This was my grandfather who used to visit, and literally next to the house there was an operating room, which was very basic, but he would get up from the dinner table, have dinner with us, have a nice chat, and then go off and do general surgery. An incredible man who sadly passed away recently. So this was, obviously a huge inspiration for me, thinking, right, this is exactly what I want to do. I want to help people just like he did. He did 50,000 operations over his lifetime. It's a huge number. A surgeon in this country would struggle to do 10,000. So the amount of good that he did and the colleagues that he worked with was enormous. And so I thought, right, I want to be a specialist like him. I want to be a surgeon. I want to work in a hospital, because to me, hospitals meant heroes. Hospitals is a place where lives are saved, and this was my view of medicine, that all the exciting stuff, all the bright people worked in hospitals, and lots of the people you'll see as part of this lecture series will be specialists working in hospitals, and I'm sure they do heroic work. But what I'm here to say is how I ended up doing something quite different. Now I sit in a general practice room, and most of my Encounters are fairly pedestrian. If you just were to put a camera in the room, it's just a conversation between me and a person. I put my hands on them sometimes, I order some tests. So how did I get there? Well, first of all, I did follow my interest into hospital medicine, and these are some of the specialties that I pursued. So here, top left there, that's a painting by Professor Sir Roy Khan, who was a pioneering liver transplant surgeon in Cambridge, where I studied. And so, as somebody interested in surgery, I spent some time in the transplant unit, and I thought for some time that I would do transplant surgery. And certainly it is a very heroic specialty where you have to work very hard and be very smart. But in that specialty and in all the others I'm about to mention, what struck me was actually, compared to a lot of my colleagues who are happy to go along and do the day job, I was always the one asking the question, well, hang on, why is this person here in the first place? Could this have been prevented? Are we dealing with this too late? So let's say you're transplanting someone's liver because they have alcoholic liver disease. Is that something we could have intervened in? As excellent as it is that we have a national blood and transplantation system, of course that's a good thing, that we can get organs for free based on donations. Is that the best use of resources? Is it the best way to run a health system? Similarly, working in orthopedics. Does anyone know what that's an X-ray of? Is it the top right? Hands up.
It's a dynamic X-ray for fracture.
Okay, so this is an X-ray of a pelvis, and the top two, I'll give you this in a second, the top of a femur, and you'll note the bright white metal in the bone. That's something that surgeons have put in to fix a broken part of that bone. And so again, this is a standard routine operation for an orthopedic surgeon, and when I was helping on those wards as an SHO, senior house officer, having to assist in those surgeries and looking at these often older ladies who are coming in, falling at home, fracturing their bones, and then sending them home. But actually it's never as straightforward as that, and a lot of these patients have a lot of medical problems while they have these fractures, and thinking, well, actually if we could keep them out, if they could be prevented from having this fracture in the first place, they wouldn't be put through all this risky operation and the period that goes with that. There in the bottom right, I worked for some time at a neurocritical care unit, which is a great thing to do, and a lot of the patients had very severe head injuries. If you were to, obviously heaven forbid this should happen, but if any of you were to have a serious head injury, that's the kind of unit that you would be going to, or a spinal injury. And they'd be monitoring you, and one of the ways that these patients get monitored is that the pressure inside their skull is monitored with this probe. So we were putting in these probes, and for all sorts of reasons, not just accidents, sometimes strokes, which is a very common disease, a common killer in this country. And again, I found myself asking the question, well, it's such a common killer in this country, maybe I could get involved in doing something about preventing that. And finally, in the bottom left, working in accident and emergency departments, where you see the full sweep of life come through the doors, but certainly one of the problems that you end up seeing is mental health crises. People coming in after they've taken an overdose, for instance. And again, you do everything you can for them. You sometimes can give them treatments to detoxify them and send them home, and that's great. But always left with that itchy feeling that, oh, I wish I could go home with them almost and be part of the story from here on in, because you just worry that they'll end up bouncing back in, and sometimes that does happen. So after a few years of hospital medicine, I decided that actually I wanted to zoom out, and I studied public health and now work as a GP. And so what I want to do for the rest of the talk is give you a few case studies of how that perspective and that fusion of that population perspective, that public health perspective, is relevant to general practice. This is kind of my conceptual view of what primary care is, not just GPs, as I'll say later, the whole team that I work in, that actually we zoom out from that end part of the story, the crisis, and we say, well, okay, it's great to rescue someone and resuscitate someone when the crisis has happened, but why is it that that crisis happened? Could we have intervened earlier in the story? So this is what we talk about when we say upstream and downstream interventions. Can we intervene in this person's story more upstream, prevent it getting even close to a catastrophe? So the kind of interventions you can do as a GP vary, and they range from things which are related very closely to an individual's risk factors and their own biology, but we are also, more so than hospital specialists usually, very much interested in and able to shape broader determinants of health. That means interested in the relationships people have with their friends and family. We think about the kind of social network and support that people have. We're interested in how economic policy and politics even can impact on people. So one example of that is strokes. So if you think about my patient on the neurocritical care unit having, being there because they've had a stroke, this is me in clinic trying to prevent that catastrophe happening in the first place. Has anyone here not know? Has anyone not heard of a stroke? Feel free to put your hand up. Ignorance is a good thing. It's good to know. So you all know what a stroke is. So these red things are arteries, and normally they are empty pipes which supply blood and oxygen to all our vital organs. But sometimes they get blocked. So perhaps if you pass that around, is that okay? If you pass it down and go all the way back. Let's have a look. So the yellow muck in there is essentially cholesterol deposits, otherwise known as atheroma. And that's a common cause for blockage in arteries. Sometimes solid deposits of blood itself can block up these arteries as well, and that's called thrombus. And so for those reasons, amongst a few others, people can get blockages in these major pipes. So all the brain that is supplied by that pipe, by that artery, is then compromised. It isn't getting the oxygen that it needs, and so it can't function. And so depending on the kind of, depending on what that bit of the brain normally does, you will lose function. You might become paralyzed. You might lose a bit of memory. You might lose speech, etc. So that's what we're trying to prevent. And so over the last 70 years, really, studies have been done which have helped us understand what causes stroke, because it's been a major killer throughout that time. And what we understand is that one of the factors that's involved is a balance of so-called good and bad cholesterols. You'll all have heard of cholesterol. Some of you will watch out for cholesterol in what you're eating. But it's not quite as simple as just reducing cholesterol, though we won't go into the details right now. But there I am in my clinic with somebody with, say, a slightly high cholesterol ratio, and then I have to have a conversation with them, because unlike the patient on the stroke unit, who's obvious that there's a medical problem and they're happy to have help, this person feels fine, quite enjoys not taking medication, or not taking any more medication. And so And perhaps medication isn't the thing, you know. There are lots of other reasons beyond diet that you get high cholesterol, and there are things like exercise, etc., that can reduce your cholesterol. And so, in that conversation, which, as I said, can look quite pedestrian from the outside, actually a very complex interaction is happening, and you're discussing a lifestyle factor, or several lifestyle factors, and you're having a negotiation with somebody who, and you're sort of speaking from a position of scientific expertise, and they are obviously an expert in their own body, and between you come up with a treatment plan. And a part of that treatment plan might be to start medication to reduce your cholesterol. Because some of these major studies that have been done, which follow people, which have, so these are so-called cohort studies, where you follow a population with a certain type of characteristics, and you say, okay, so you're a man who's 40 years old, who is from an Indian background, say. And then you follow that person, and you say, okay, at time 0, you had this cholesterol, and you had this blood pressure, and so on. And let's see, after 5 years, after 10 years, and these studies are now going on and on into their decades. And so we know quite well now, from studies across thousands of people, the answer to some of the questions like, what's important in terms of preventing strokes? And we know that, for instance, reducing cholesterol levels is a very good thing. How do you convey that to somebody? How do you convey very complex population data, which requires a degree to really understand the papers? That's part of the art and science of medicine and general practice. And so I and my colleagues have to try and convert that kind of science into an everyday conception and a persuasive argument. Not that I'm particularly there to start or not start a medication, but to provide somebody with information such that they can make a decision about their own body. Has anyone seen a picture like that before? Yeah? Where have you seen a picture like that? Biology A level. What did they tell you about that at biology A level? Okay. Okay. And your friend? Biology A level. Okay. So I'm not sure what they told you at biology A level. I'm glad that they're covering it. Essentially, it's a way of helping people imagine these very complex statistics. Because you don't know. Even if I have high cholesterol, I don't know if I'm the person who's going to die of high cholesterol. And you could conversely have low cholesterol and still die of stroke, despite having a low cholesterol. So the only thing we can do is to tell people the probabilities. Based on data of people like them, what is the probability that they will suffer from a certain condition? So the way it's phrased, or the way that I try to phrase it to my patients, is to say that, okay, if we, based on your cholesterol today and all the other factors about you that we know, like your blood pressure and so on, and your age, if we were to roll the clock forward for 10 years, we have good enough data to know and to tell you pretty certainly that if there are 100 people, there probably are about 100 people here, if there are 100 people exactly like you with all the same characteristics as you, and we roll that clock forward for 10 years, this is what would happen to them. So 8 of those people would die from something else. 70 of those people would have neither a heart attack or a stroke, which are the things that we're trying to prevent. And then there's this middle group. And so 22 of those people would have had a stroke or a heart attack, if you roll the clock forward. So for some people, that's persuasive, and they say, oh gosh, that's a high number, I don't want to take my odds on that one. Other people are happy to play Russian roulette with that kind of statistic. But then, what can you tell them? It's false to say to them that by taking a medicine like a statin, which you've probably heard of in the press, that their chance of getting a stroke is 0. That's obviously not the case. but you can say that the probability of them getting a stroke is reduced. And the way to express that to them is to say that in that room of 100 people, if we were to have put them on statins, 8 of them would have been saved. We can't save them all. There are other things at play, but 8 of them would not have had very catastrophic illness. So that's the kind of discussion that we can have, and I never know which of my patients are the ones who have been saved. You know, these people who do end up on medicines like statins, which lower your cholesterol. Obviously, you never know if you're the one who didn't get a heart attack at a certain point, but the studies tell us that a significant number are not having heart attacks and strokes, so we can rest assured in the data that we're doing a good job. So beyond biological factors, there are broader lifestyle factors like diet and exercise that are relevant too. And so think about my elderly lady who comes in with a fractured neck of femur, which, oh, it's down here. Do you want to pass it? Pass that around. So that is a right hip bone, and that, actually, point it out. The most common place where this bone breaks is there, the so-called neck of the femur, and there you go. And so this down here on the bottom left is what happens. So you have what in you or I would be an innocuous fall. You and I would bounce and get up and get on with our everyday life. But in some people, their bone is brittle and it shatters. And it breaks in a dangerous way, in a characteristic place. And you can't walk on your leg anymore as a rule. And you are incapacitated and need surgery usually to get back on your feet. And it can be, as I said earlier, quite catastrophic in terms of your health outcomes. And people can die of the stress that puts on your body. So what can we do in general practice to prevent this happening? I'm thinking of patients of mine who come to me with minor rib fractures, for instance. So they might knock themselves on a kitchen tabletop, or they've just sort of bounced on a car at some point, and they tell me, "Oh, I think I've fractured a rib. Doctor, can I have some painkillers?" And as you probably know, GPs have about 10 minutes with patients, so that's a nice, easy one if you're feeling lazy, and you can sort of say, "Oh, well, there you go. There's some painkillers. Off with you," because rib fractures heal themselves, and there isn't actually anything for that problem that you can do medically to help. We don't operate on fractured ribs. We don't do any more monitoring on them. However, that's the kind of case. That's the kind of person that I say to them, "Okay, hang on. Let me stop you there, and let's ask a few more questions." And what I'm trying to get out of that person is certain risk factors, how they eat, how they exercise, and try and find out their other risk factors for a condition called osteoporosis. Osteoporosis is really the reason this happens in some people and not others. So in normal bone, if you didn't know already, bone isn't solid like that model. It's not just solid material all the way through. There are holes inside bone, and that's normal. But there are various factors that can make your bones thinner. In fact, that's a normal process. One of the things that makes bones thinner is the reduction in hormones, or sex hormones, as we get older, particularly in women after they go through the menopause. So that's a normal thing, and that's why it is often older ladies who get fractured necks of femurs. It's 4 times more likely in that population. And so instead of having a nice strong bone, their bones thin out. And what I'm trying to do is to get people at this stage before they get here, or if they are here, try to keep things at bay. And so how can I do that? Well, again, based on studies that have been done, we know the important risk factors that make you more likely to have this, because we've studied people, populations across time. And so we know that, for instance, how you eat, as I said, how much impactful exercise that you do, how much you weigh, whether you smoke, whether you take other medications like steroids. All these things and others affect your bone health. And so you can plug these factors, if you take the time to talk to your patients, into a calculator which works out a score. So the score I use is called the FACT score. And then again, before the problem has happened, I end up confronting a patient with data. So for instance, with this lady, I might tell her that, okay, she is 57, and so this chart tells us how she's doing compared to another lady of her age. So she could be anywhere. If you can see on the x-axis it says age, and along the top of the y-axis, that's the 10-year probability of a major osteoporotic fracture, something like this. A fracture that wouldn't have happened if this person didn't have thin bones. And so I can tell her that, okay, there's 3 zones that you can be in: green, amber, and red, with increasing alarm as you go along that spectrum. And she's doing okay, you know, this particular lady, because that X, as you can see, is sort of on the borderline between normal and at the stage where we would refer people for scanning. It's a particular kind of scan where you can look at this. Most X-rays don't look specifically at this, but there's a particular kind of X-ray called a DEXA scan, which looks at how holy your bones are. And some of you may have had that kind of scan. Most of you women will at some point be offered that scan, certainly, and men too, if you have risk factors for osteoporosis. And based on that scan and that statistic, you can say to someone, okay, so this is how we proceed, because there are interventions that we can do, there are medicines that we can give, there are lifestyle measures that we can encourage in general practice that can incrementally make changes to their life, and they can slow the decline. You can never turn someone's bones from this to this, but can we slow down the thinning of their bones so that 5 years, 10 years after I have that conversation with this lady, because I've had that conversation, and because she's on a certain medication, or because she's made certain changes to her lifestyle, she falls, because we all fall at some point, and bounces instead of breaks, and then she gets up and gets on with her life. And again, she doesn't know, and I don't know, whether her life and her hip was saved in that moment, but the studies, again, tell us that by focusing on risk factors like the ones up here, and by intervening early with medicines which can help slow down that process, we can we actually save lives. Now I'm thinking about the transplant ward and the liver transplants that excellent surgeons like Professor Sarah Roy Khan were doing. And of course, there is always going to be somebody who needs a transplant. I'm not suggesting that we don't need specialists, or we don't need surgeons, we don't need hospitals at all. Of course not. We can't prevent everything. But you know, when you open up someone's abdomen and you see a highly cirrhotic liver, perhaps with liver cancer embedded in it, and you realize that this person's story has involved years and years of alcoholism, for me that's a tragedy. That's too late. And so now, as I teach on public health, and I talk to patients on factors broader than just how their liver blood tests are doing, which are things that we measure, and we do manage a lot of patients with alcoholic liver disease who aren't severe enough to be in a hospital. We do all that. We do the blood tests and the scans and so on. But what's really valuable in general practice is the ability to look at a problem more holistically and say, okay, why is it that people in this country drink so much? We have a problem. And so, it's all well and good having an excellent, smoothly efficient liver transplant scheme, but if we can do something about this, then perhaps we could stop some of these livers changing beyond repair. And so this is the kind of thing that most of you would suggest if I were to ask you, what factors are associated with alcoholism. I imagine most of you would have suggested some of those things. And you're right to. You're right to say that mental health is a risk factor for alcoholism, as well as those other factors. Homelessness. 1 in 69 people in Brighton today are homeless. As a GP, I care about that. In hospital, that statistic didn't mean so much to me, but 1 in 69, potentially, of my patients is homeless. 2 or 3 people in this room, by equivalent. So, if that's a risk factor for alcoholism, shouldn't I care? Shouldn't I be involved in trying to learn about that problem and trying to do something about it in the first place? But there's other factors too. So society and the social world that we live in also defines whether we're likely to drink. And this is, again, probably common sense to you, but probably not what you would have said if I'd said, what are the risk factors for alcoholism? The kind of culture that you live in, the kind of household culture, but also the culture of your friends and your colleagues and so on, whether your work colleagues drink to excess, whether it's okay for you to be with your friends and whether to not drink and for them not to ask you a question, etc. That this is how dangerous drinking starts. But there are other factors too. So socioeconomic status, essentially that means how rich you are and where that puts you on a sort of ranking. And it's not quite straightforward because people at both extremes of wealth drink to excess, but that is a relevant factor too, and poverty is an important factor for drinking. But also things that you might well say are beyond the remit of a GP. These are also interesting to me too, and there are GPs and other doctors and health professionals who are interested in alcohol pricing, how you tax alcohol, because there are studies that suggest that if you tax it differently, people's spending habits and therefore their drinking habits change accordingly, and that can have a huge impact. But there are political pressure groups who are pushing against that kind of change. Because this graph, which shows dangerous drugs, came out of a Lancet paper, and that's really the sort of the research that we have to confront. Alcohol is a drug that most of us, not all, but most of us will partake in fairly regularly, and it's a socially sanctioned and acceptable thing to do. I'm not here to tell you to preach and say that you shouldn't drink. I drink alcohol, but in terms of the number of people who drink and the severity of harm both to physical and mental health across your lifetime, it is the most dangerous drug in this country, bar none, including heroin, including crack cocaine, etc. So when I have a patient who comes to me with a slow healing graze on this is a true story, a slow healing graze on his cheek. The story didn't quite add up, He comes to his GP about a little graze which hadn't been healing for a while. So okay. So I start probing and I eventually reveal that although he doesn't think it's a problem, he drinks to excess. And that's part of the reason that his skin doesn't heal, by the way, because if you drink to excess, it affects your immune system and your liver and other factors that help you heal and regenerate. And so, not in one 10-minute consultation, but over decades, over years, you can try to build up a relationship with people and a rapport and an agreement, really. You know, there's not much in it for me, but for my patients, I try to come up with a plan that sort of puts together the scientific and medical knowledge and their own priorities and try to push things forward in a constructive way. And you know, you won't always win. I'm not saying that every alcoholic can be turned sober, but again, if you look at the data on this, it is worth the time in primary care early on to intervene in these kind of patients, because it prevents permanent liver damage. And so all these drives we get for people to join the organ donor register and so on, which are all fine and excellent, and you know, you should all do that at some point. We would need less organs if we could do this stuff properly, if we could prevent and intervene and have proper conversations with people. And the final case study involves depression. And mental health is a huge problem in this country and across the world. It's thought to affect nearly half the world's population in some form or another. And it's an under-investigated, it's an under-researched, under-treated problem on the whole. It's something we don't like to talk about. It's something that even once we have a diagnosis, we are not good at treating people fully. And you know, when some of you will end up in medical school, maybe teenagers, and when you go to medical school, they'll teach you this. And this is all correct, by the way. I'm not saying it's a lie. But this is the connection between nerves, and in particular nerves in the brain that make you feel good or not. And so there are particular chemicals called neurotransmitters which cross from one nerve to another, and how much or how little you have of that determines how good or bad you feel, essentially. It's a lot more complicated than that, but I'm simplifying it. And so we know from the basic molecular science research that's been done decades ago now that this is what's wrong, essentially. And so for many years, that in my head, that is depression. It's a misfunctioning synapse. It's a shortage. Of a neurotransmitter. It's sort of a drop in the sea level of something like serotonin, one of the neurotransmitters. But synapses and nerves and brains and people don't exist in vacuums. And so since graduating and since working with people as a general practitioner, I now think about some of the broader factors. Of course, there are always going to be people who are depressed, and some people just are wired, if you like, to have less of certain chemicals transmitting between their neurons. But in some people, it is a response. It is a response to a social situation. It might be a response to poverty. It might be an enduring response to bereavement, etc. Or abuse, or another kind of trauma. And so, how do we deal with that? And how do we stop that person getting to A&E in crisis, perhaps unconscious, and needing resuscitation and reviving? How do we stop that well in advance? Well, not everyone goes to their GP with that kind of problem, but a lot of people do. And so it begins with a conversation. It begins with questions. And they may well be coming to you for another reason. I'm looking at some of the medical students in the room. And I want you to think, when you see somebody with some other medical complaint, medical problem, about their mental health, even because it's a very difficult thing to mention. And sometimes it's so off our radar, we don't even think to talk to a doctor about it. But when you bring it up, people do talk about their lives, about their stories, about their setbacks. And what we can do, as I said, in this sort of otherwise pedestrian interchange between GP and patient, what's happening here and what's happening between me and my patient is actually quite complex and meaningful, I hope. And so what can seem like a tangle of issues, and what is a tangle of issues, whether it's childhood trauma and abuse, or recent bullying at work, or whatever the issue is, our job in primary care and the mental health profession, of course, is to sort of deal with people, try to unpick their problems, try to help them constructively get to where they want to go. We're not here to make everyone elated and as happy as possible, but we're here to help people function and be the people that they want to be and do the things they want. So of course we sometimes prescribe medication which directly adds certain neurotransmitters to certain parts of the brain, and yes, they do usually help people feel better. But there are other things that can do the very same thing, partly talking to people and improving your well-being in other ways, whether that's to do with eating better, sleeping better, exercising better, having better friendships, having better social connections, and so on. And speaking of social connections, a more recent movement really is to appreciate that, particularly in general practice, what we have is a person in the room, but what they bring is a whole lot of social problems. And unfortunately, the response from our profession to that for decades has been heart-sink. I'm not here to deal with that. I don't want to know. I'd rather if we could just simplify this to the medical problem. I can give you a pill or not, and you can go away. But that's not how life works, and people do have problems. And so they may well come to you explicitly or indirectly carrying this kind of baggage. And it's for us to have those conversations to understand what it is about their life that's missing. Is it that they're lonely? Is it that they're, not finding meaningful work? Is it that they are that they've lost their narrative, that their story in some senses has changed? For instance, if you lose someone like a patient today who is sad because they've lost their mother and father who they were full-time carers of, but it's actually more than just a bereavement, it's a loss of narrative. This person has fully been caring for that person 24/7 for years, and now what do they do? So there's all kinds of scenarios where we, and some of you as general practitioners, will try to re-plug people back into the stories, the narrative, the kind of lives that they want. And so part of that is this thing called social prescribing. So traditional medical, pharmaceutical prescribing is, you come to me with a problem, I write a script, I hand it to you on a green piece of paper, you go to a chemist and take some medicine, and I cross my fingers and it makes you better. More than half the time it won't make you better for something like depression. But we take that chance. Social prescribing is where we give someone a recommendation, or they themselves give themselves a recommendation, they might think of it themselves, of how they could be helped. So, in this city, a lot of the patients I see have problems with housing, or they just need a community group to engage with. These are within the remit of a doctor. For too long, GPs and the medical profession said, oh, well, that's not our problem, that's for social workers, that's for so-and-so. That's our problem too, because they're our patients and those things impact on the health problems that they come to us with. And more than that, general practice was one of the few places where people come to with problems. where else can you go for free to speak to somebody who's going to, for sure, guaranteed, listen to you for at least 10 minutes, and you know, they might not be exactly the right kind of person for you, you might not have the chemistry, but you can tell them about your problems. There isn't really somewhere else in our society where you can do that. So it is a privilege to be in that position, and even though I may not be directly the best person to help people for these kind of issues, they come to, people like this come to us, whether they're socially vulnerable or marginalized or lonely or whatever. And now there is a growing scheme to point people towards the right kind of community resources, because in places like Brighton, but actually across the country, there are lots of groups helping people who are struggling to find housing or to write letters to their landlord, or there are community gardening groups, or there are arts and well-being workshops that they might go to, and so on. And so, in all these cases, and now with that sort of memory of the hospital behind me, I try every day to sort of try and think ahead and what problems could happen and try to intervene, and with that sort of public health perspective, try and act as upstream as possible. And it's a different kind of reward. It's quite, I'm sure if there may be a surgeon in the room or someone who's interested in surgery, it's extremely rewarding, I can tell you, to sort of do something surgically to someone and the next day tell them you're cured, you can go home now. It's wonderful. But it's a different kind of reward to intervene upstream and to not directly see the benefits, perhaps, but to know that those benefits are happening across the population because you're doing the job. So what makes us different in general practice compared to hospital medicine? Well, the prevention stuff that I've talked to you about, but also these 5 values which the King's Fund have drawn out. So the fact that we, compared to hospital care, should be accessible. We know our patients, we see them time and time again, so we can offer continuity and an ability to treat patients who feel known and therefore at the center of their care, and we can take all their social and medical factors at play and give them holistic care. We can, as I just said, coordinate community groups and hospital specialists and others, all orchestrating the whole team to come together for this patient. And crucially, we are rooted in the community, and we want to keep people at home and out of hospital in the first place. And so that initial cartoon I had of a sort of heroic doctor has changed in my mind, and now I have a team around me, and it's a much less individual pursuit than you think. There are excellent nurses, paramedics, receptionists, administrators, the list goes on, of people that I work with in primary care who are all doing their bit. And for lots of you in the room, you know, general practice will not be the thing for you, and that's fine. You know, I'm not here to say you must do general practice and nothing else is worth doing. But as a profession, what we do is really valuable. It's one of the most, in fact, it is the most efficient sector of the healthcare system, and it's often the most under-resourced. If only we could fund general practice and primary care better, we would prevent so much of these problems, so many of these problems ending up in hospitals, and save money down the line. And so, okay, that's all very well and good, but I'll just leave you with a few thoughts about perhaps, regardless of what you do going forward, even if you don't become a health professional of any kind, how you can perhaps save a life. And save lives all the time, and you do, because you might be the one who, you know, tries to encourage yourself and those around you to stay fit and healthy, whether it's through exercising or through healthy eating. You might be the person who has a difficult conversation with somebody, whether it's to do with mental health or to do with alcohol or smoking or whatever. It's a very difficult thing to do, but you are all out there are agents of change for health too. It's not all on the healthcare professionals to look after people's health. And then there are broader things like changing society, which is an ambitious thing to want. But, you know, could we imagine a healthier city, a healthier country? Could we design our roads and our education system and so on to enable people to live healthier lives? To say, cycle more and walk more rather than drive and reduce air pollution and so on. And for those of you who are interested in the NHS generally, and I've got a couple of handouts here with some information for you. But for those, regardless of what you do, most of you will be British citizens using the NHS, and there are plenty of people who are campaigning to defend the NHS and its core principles of providing holistic, comprehensive, free care to everyone at the point of care. And unfortunately, there are threats to that kind of service and privatisation threats and so on. So these are all kind of ways that you can get involved. Some of them are very obvious and direct, and some of them are less direct, like getting involved in food poverty, or campaigning for it, or being aware of it and trying to address that kind of problem. Thank you. Any questions?